Hello and welcome to episode 157 of APM Success. Today I'm re-releasing an early conversation with Dr. Ed Mariano. Starting in a few weeks, we're going to have fresh content every week, but during this summer season of travel and other craziness in the financial planning business, which is growing by leaps and bounds, which is awesome, re-releasing some of this content has been very helpful. So Dr. Mariano is one of those physicians who early on was really helpful. For me personally, when I was just getting started in this space, I went to I believe it was the 2018 Fall ASRA meeting in San Antonio, showed up to this conference with really not much more than a thesis, a professional vision for the thing that I thought could happen, that I figured that existed only in abstraction in my mind, that I thought could exist in reality. And so I went to this conference not knowing anyone, but thinking, I bet there's a way to do specialty-specific financial planning for physicians in anesthesia and pain. And I wanted to put my money where my mouth was, so to speak. So early on, I signed up for this dinner, one of those, sign your name on a sheet of paper with 7 strangers and make some new friends. And Dr. Mariano and Dr. El Casabani from Philly and Dr. Gary Schwartz from New York. These 3 gentlemen were so kind in welcoming me into their community and showing me the ropes a little bit. And it in no small way really helped to affirm and reaffirm my conviction about what I was doing professionally at that time. Now 4 years have gone by and here we are, and it's been a great ride. Dr. Mariano is now the president of the California Society of Anesthesiology, just further evidence of his not only clinical excellence, his research leadership, but also his desire to really help others along. And I think it's really broadly recognized. He's one of those real advocates and leaders for the specialty who I'm really grateful to have gotten to know a little bit over the last couple of years. So enjoyed this episode with Dr. Mariano. Hey, it's Justin Harvey. Thanks for tuning into the Anesthesia and Pain Management Success podcast. With APM Success, we take a close look at important topics pertaining to business, practice management, personal finance, and careers for anesthesiologists and pain management physicians. We work hard to take your critical questions straight to the experts. Thanks for listening. Welcome to episode 30 of the Anesthesia Success podcast. I'm pleased to be joined by Dr. Ed Mariano. Ed is a board-certified anesthesiologist, and he's double-boarded in anesthesiology and pediatric anesthesiology, and currently serves as the Chief of Anesthesiology and Perioperative Care Services and the Associate Chief of Staff for Inpatient Surgical Services at the VA in Palo Alto. He's also the Program Director for the Stanford Regional Anesthesiology and Acute Pain Medicine Fellowship, and I'm very pleased to have Ed here today. Ed, thanks for joining me.
Thank you so much. I appreciate your inviting me.
To start us off, I know you're very involved not only locally there at Stanford and at the VA, but also with some of the state and national organizations. So maybe you can give us just a brief overview of the current scope of responsibilities and all the things you've got going on right now.
Yeah, thanks, Justin. Yeah, no, it's a really interesting career, I have to say. I mean, I try to do the things that I know I can give 100% effort to, and so I try not to spread myself too thin. But that being said, I do a lot of things now, all of which I feel like are really important in terms of trying to move, I think, our profession in anesthesiology forward and try to develop a lot of new leaders. So, for example, as you mentioned, I'm currently the program director for our Stanford Regional Anesthesiology and Acute Pain Medicine Fellowship Program, which I'm very happy and relieved to say has passed our 2-year standard site visit for ACGME, and it has continuing accreditation. So that's a big load off. So we feel good about that. I also, as you mentioned, I work primarily here at the VA Palo Alto, and I'm chief of our anesthesiology service. And I also have an associate chief of staff title. So I oversee all of our inpatient surgical services. And then as part of my role, respiratory therapy at Palo Alto Healthcare System is also under anesthesiology. So I also oversee that. And in addition, we also have many of our physicians have diverse clinical practice models that include anesthesia, pain management, critical care. And so I also oversee our clinical activities in those areas. On a broader scale, at least on campus, I also serve on a number of committees within Stanford's Department of Anesthesiology, Perioperative Pain Medicine. I sit on our governance committee. I sit on our Appointments and Promotions committee. and then also our department finance committee. So that way I have a fairly good idea of how the department runs and where it invests, especially in terms of programmatic support for the faculty and also all the trainees in the department. Outside of there, I serve as the speaker of the House of Delegates for the California Society of Anesthesiologists. And as part of that role as an officer, I serve as a delegate from California to the American Society of Anesthesiologists House of Delegates. I chair the ASA Committee on Regional Anesthesia and Acute Pain Medicine. And I also currently am on the board of directors for the American Society of Regional Anesthesia and Pain Medicine, which is the subspecialty society focused on the spectrum of pain medicine. And those are probably my big ones.
Okay, awesome. Well, that is a lot. And I'm curious to know, with this really long list of it sounds like pretty demanding responsibilities. How do you protect yourself from not getting spread too thin, as you said, and evaluating whether or not something is still a good fit for your priority list?
Yeah, so you can't do everything. And I think all of us who go into medicine, I think we know that it's not just a job. Otherwise, there would be a lot of other job options that have better hours and probably give you more money and create less debt.
Yeah.
So it can't be that. And I don't think that physicians know that. So when you come out of your school, when you finish your training in residency, your fellowship, you know that going in, that part of what makes medicine special is that it is a calling, it's a vocation, and the work aspect, the sacrifice, is part of the reward. It actually, that by giving that part of yourself to society, to improve health, to improve outcomes for patients who have to have invasive procedures like we do, that actually makes it worth it. So I don't think any of us really think that we're ever going to be truly balanced. That's one of my pet peeves is I'm not a work-life balance person, only because I don't think that realistically you can expect to have these two buckets of work and life when you're a doctor, and you can't expect them to be perfectly balanced. But I do believe that integration is key. And I also believe that there are certain days when maybe I'm not 100% doctor. Maybe I'm 5% doctor. It'll never be zero,
right?
Because that's part of who I am. But I do think that you have to decide when you're able to give 100% when you can't. And so things that I do, I mean, I actually thought that academics was the furthest thing for me when I was going through my training. I did not think that I would have research as part of my career. I went to medical school wanting to be a good doctor and take good care of people. And I felt like that core relationship of improving that the patient well-being and patient health, I think, is the thing that I always come back to when I'm trying to ask myself, should I do something or not? So for example, when I'm at the bedside with a patient and I'm taking care of that patient, I'm in charge of anesthesia and perioperative care, pain management, then I know that is 0 degrees of separation between me and making sure the patient has a positive outcome after surgery. Now, when I'm teaching someone that I have a resident, I'm working with a fellow, or maybe I'm giving a lecture, then that's sometimes 1 degree of separation. I can think, well, if I teach this person, if I can give some kernel of information, if I can provide the evidence in a lecture hall, and that person now goes back to his or her practice setting and can do something to help his or her patients, then now that's only 1 degree. So research, interestingly, I got into really late in my career, I feel like, just because I'd only started research at the end of my residency for the first time ever. But I got interested because someone had asked me a clinically relevant question, and I thought, if I knew the answer to this, then I could apply that in my clinical practice. And I try to do that with all of the research projects that I do. I think, well, does it matter? If I answer this question in a research project, can someone use that information to take better care of the patients? And that, to me, I mean, that's still 1 degree. And then probably the last thing that I got into career-wise over the years was really advocacy and just protecting the practice, allowing clinicians, I think, or facilitating good clinical practice through advocacy. And I realized that the infrastructure, the structure that we work in, the healthcare system at large, has so many important influences on the way people practice medicine, or just healthcare in general. And so I realized that if doctors, if I don't represent the interests of patients and clinicians on a bigger level, then other people will, and they may not make the decisions that that we believe in that will really truly help us take good care of patients. And so I realized that advocacy is also another important activity that if I can help make the system easier for clinicians to do the right thing, they will.
Mm-hmm.
And so I consider that 1 degree. So I have this 1 degree of separation rule in general, and that's usually the way that I try to decide, is it worth it or not?
Okay. Awesome. So something you mentioned that I'm really curious about is the somewhat recent, last couple of years, and you said you just rolled over the 2-year anniversary of the ACGME accreditation of the Regional Anesthesiology fellowship there at Stanford and a couple other sort of pilot programs nationally. I'm really curious, what kind of work went into starting a new ACGME accredited fellowship? I'm sure that's one of those things that it's sort of like turning the aircraft carrier, I would imagine, getting institutionally involved and starting something that doesn't currently exist that's going to be replicated everywhere and needs to have a lot of processes and procedures and things standardized. I'm curious, what did that process look like for you? How long did it take, and how did you feel kind of when you got that letter in the mail that said, Stanford can now offer this in an ACGME accredited fashion?
Well, that's an interesting story. We were actually talking about this recently, just amongst various colleagues. We have a manuscript that's actually in review right now. Just talking a little bit about the history of regional anesthesia in the United States and how training has changed so much. And I've been very fortunate to be part of this process that has gotten us to where we are right now in terms of having national accreditation for our fellowship training programs. And I think the journey there also wasn't one that I chose as much as I feel like it was chosen for me in a way. I was really interested when I started at UCSD 2 years after the very beginning of my academic career, following the completion of my fellowship. I started a new fellowship there, and it was the first 1-year regional anesthesia and acute pain medicine fellowship based in California. And in order to prepare for that, what I did was I attended the spring ASRA meeting because I wanted to meet other fellowship directors. And there were not a lot of fellowships at the time, approximately a dozen, give or take. And that fellowship directors group, although it was informal, was highly organized. And I have to give a lot of credit to the Hospital for Special Surgery in New York. The chair there, Greg Ligori, their primary, really lead administrative and education focused administrator there is Mary Hargett. And the two of them would organize meetings for the fellowship directors 2 times a year at the spring ASRA meeting and the ASA. And they continue to this day. And they would host this meeting so that way a voluntary group of fellowship directors and just interested regional anesthesiologists who focused on education could get together and discuss, well, what should fellowship training look like? And interestingly, before the ACGME program requirements even came out, this voluntary group had put together 3 different versions, an original and 2 updates of recommendations for fellowship training. And so I didn't have to start from scratch, which was great. And when I started the fellowship, I followed the most recently published guidelines for fellowship training, and I joined this group. And we went along this interesting path where we would meet 2 times a year, and almost reliably, at least one of the meetings that year would be focused on debating the merits or demerits of pursuing accreditation. And this is a very passionate group of people. Those who believe in regional anesthesia and the potential benefits for patients have to be passionate to make it work in their own institutions. And so you get all these people together, and we used to argue back and forth for years. And then in 2013, it happened to be the the spring annual meeting that I chaired. It was in Boston, and we had our annual fellowship directors meeting. It was Saturday morning. We always meet on Saturday morning at the spring ASR meeting. And during that meeting, we had the same discussion. And I must have been coming off like a high of almost being done with chairing the meeting. And the subject came up, and all of the people there in that room, and we never agree on anything, but we unanimously agreed that meeting that we would go ahead and pursue accreditation for the fellowship. And there you go. I
Wow.
was the one person. I mean, we were talking about this, and I think because I had gone back and forth, pro and then con and pro accreditation, I was asked to lead that task force and see what it would take in order to pursue accreditation for the fellowship. So I became the lead for this task force. I selected people amongst the fellowship directors who felt favorably and who were also fairly antagonistic towards accreditation, because I didn't want a group of people to work with me on this project that would just echo the same feelings.
Right.
It's not constructive. And I wanted to know, like, well, what are the big concerns? Like, what are people, what's holding people back from trying to validate a national standard for what training should look like? Because at that point, I think we were already over 60 programs in the United States and Canada, and in a pretty short amount of time, right? So if it go to a dozen to 5 times that many in roughly almost 10 years, you can imagine that there were a lot of different ways people would interpret fellowship training.
Right.
And I think what became really important to me at the time was, what does the certificate mean for the graduate? When you finish your program, now over 60 different programs and with no national standard, what does it mean when you go and look for jobs?
Right.
Because maybe the strength of the program is the reputation. Maybe it's name recognition. Maybe it's a particular mentor or a set of mentors at a program. Maybe those are the people who end up recommending you for your job. But chances are your first job is not going to be your lifetime job. So what happens when you move? And what does that certificate mean later? So I think the pursuit of accreditation really became about trying to standardize the quality and quantity of training that the fellows receive, so that way, by the time that they're done, everyone anywhere knows what it means.
Right.
So that process, I looked up, like, well, what do other programs do? And the obstetric anesthesia fellowship programs were the most recent specialty program in anesthesiology that had been accredited. So I contacted OB anesthesiologists that I knew to try to get some advice and to see, like, what were some of the difficulties? How did you prepare your packet? I looked up on the ACGME website, found that they needed some justification in 8 different domains so that way you could express why does this fellowship training program have to exist? Why does it have to be a defined subspecialty? And interestingly, which core specialty should it be affiliated with? Which I think was a really interesting point, because for us, we see that the pain medicine fellowship is a multidisciplinary fellowship, but it's so multidisciplinary that you can have multiple different residency program graduates apply to the same fellowship program. And the way that we saw regional anesthesia, I mean, is perioperative pain medicine first. It's acute pain medicine, or at least a trauma-related or injury-related acute pain medicine second. How do you define that? And what is the core specialty? And I think, at least we're biased, of course, but we really and truly believe that anesthesiology should be the core residency program for that particular fellowship. And so that has to be defined too. So all in all, to make it a longer story somewhat shorter, it took about 5 months to put together the packet that I submitted directly to the CEO of the ACGME. It was 161 pages total.
Wow.
It had numerous appendices because you had to show proof of each of those 8 domains.
Okay.
And we waited after that for probably almost a year before we found out that ACGME had been able to meet to discuss it. And they approved it as a subspecialty of anesthesiology.
Huh. Awesome. Well, congratulations. I'm sure
Thank you.
that was a really exciting period of time, kind of waiting for that decision to come down. I'm curious, I know that the ACGME is funded through CMS, and that it's pretty rigid in the funding, meaning we can't just, for example, double the amount of residencies that there are, or residency seats in a program, just because of the funding constraint through CMS. So, from like a financial standpoint, how does that work with funding?
So it did affect. So that was one of the actually. I have to say that was one of the more controversial topics related to deciding whether we would try to pursue accreditation nationally or not. Was at the time, because all of those fellowship programs, over 60 fellowship programs, were non-accredited. They were all internally funded, and so the way that you could have those fellows pay their own way, so to speak, is they would work for at least one day. Some fellowships even had the fellows work 2 days out of their 5-day week as attendings in the operating room, just providing anesthesia or supervising rooms in order to earn a salary. So they would earn their base salary that way, and then they would be trainees for the remaining amount of time, either 3 or 4 days per week. And some programs still do this because right now, not all fellowship programs in regional anesthesiology and acute pain medicine are currently accredited. But that was one of the hot topics. And one of the things that we discussed in terms of making that decision is that you can't decide if a training program is a true subspecialty if you're influenced by the financial constraints of paying for their training. Does that make sense?
I think so. Can you expound on that
Yeah.
just a tiny bit?
So the first question we asked the fellowship directors in if the economics were not part of this, would you consider your training program to have sufficient curriculum, to have sufficient material to teach fellows 100% of the time? Do you consider your fellowship a 1-year fellowship program, or do you consider it an 8-month fellowship program?
Right.
And that's the first question, right? And so is it an 8 or 9-month fellowship, or is it a 1-year fellowship? Let's say, well, it's a 1-year fellowship. Do you think that you have enough material today that if you encompassed all of regional anesthesiology and then all of acute pain medicine, truly trying to provide a product at the end of that year where now your fellowship graduates are experts, not just in the science and clinical practice of acute pain medicine and regional anesthesiology, but they also have the leadership skills in order to help develop some of those programs at their new practices, because that's really a big driver for trying to train these new experts, is that they'll hopefully improve patient access.
Mm-hmm.
So when you ask the fellowship directors that, of course, the answer is yes. They say, of course, in our 1-year fellowship, we could train people for 100% of the time. So you say, well, if that's the case, then why would they be out of your training program for 1 day a week or for 2 days a week, where they're not dedicating that time to learning what their eventual area of expertise is going to be? And so I think on its merit, we had that discussion. It does affect, for example, when you have an ACGME accredited fellowship, you have to work with your own GME office locally in order to determine how much funding, how many trainees can you support, and that's really determined through a relationship between your local GME, the designated learning officer, and ACGME.
Got it. Okay. Interesting. And then is the trend, do you think, for more and more of these programs, they're going to pursue accreditation in the next handful of years?
Yeah, that's what we're seeing now. I mean, I think we have an association for the specialty program directors meeting that gets together at the Society for Academic Anesthesiology Associations in Chicago every November. And last year, when I gave the update, we had 22 accredited fellowship programs in regional anesthesiology and acute pain medicine. Yeah, and this year we have 31 already.
Wow.
And I know that there are multiple applications that are in the works, only because I've been contacted by multiple fellowship program directors for advice about applying. And I say this, that we meet 2 times a year, as I mentioned, and every year I tell people, if you are starting an application and you don't know where to start, email me. I'll send you ours.
Yeah.
I will send everything that we've done because um, it only helps graduate more trainees, right?
Right.
And so I've been pretty open about just sharing everything that we do. And so I know that there are other programs that are thinking about it because I've sent multiple people
Yeah.
recently our application and some little tips and tricks related to trying to get your application done and just steps in the process that come from our fellowship coordinator.
Yeah. Yeah. Makes sense. Awesome. You said something earlier that really struck me, and I wanted to circle back on. You said for physicians, they are as a class of professional a very conscientious bunch who take the vocation very seriously. And you use this phrase, "The work is the reward," in many cases, and you're talking about work-life balance and that kind of thing. And it made me think about the current state of, this is true across most specialties, but the current state of medicine and the dynamics of different stakeholders, whether it's like patients or doctors or insurers or other advanced care practitioners or hospitals. There's a lot of different parties who all have a certain set of interests. And not all of these groups are as, looking at the big picture, I'll say. And so I'm curious with the way that you see anesthesia functioning right now and some of the we'll call them secular trends, the things happening in healthcare and the pressures in different directions that are frankly just demanding more and more and more of doctors for less and less and less. Are there any areas in which you're either particularly alarmed or particularly encouraged? And how would you try to frame the current landscape for somebody who's listening in and interested to know your thoughts?
No, I think that's ultimately the most important question, especially to potential applicants into our specialty.
Yeah.
I'll focus more on anesthesiology just because I mean that's what I do, and also I think it's an interesting case in point for other hospital-based medical specialties.
Yeah.
One of the difficult aspects I think in choosing a specialty, first and foremost, is as a medical student, you're not exposed to everything, and that's one of the tough things I think that every medical student goes through is, well, what do I do for a living? Knowing that I'm coming out of medical school with debt, and the average physician career is at least 30 years. That's a really hard decision to make, and then you add to that the fact that most medical students will never rotate on every specialty, especially if you include subspecialties of medical specialties. That's impossible. You can't. There's just not enough time. So how do you make that choice? And I think for the medical student applicant who's interested in anesthesiology, I think that there are some important considerations. And one is it being a hospital-based medical specialty, we, with some exception in terms of, for example, for pain medicine, but in general, as a practicing anesthesiologist, you generally are not the person who brings the patients in. And so much of what we do, and I think that we have to embrace the identity of your specialty, and anesthesiology is a service-driven specialty. It's important. It doesn't take any value away from the contributions of anesthesiologists to say that. If anything, I think it's really a key. I think it's a key element of anesthesiology that should attract the potential anesthesiologist.
Right.
Because I do think that anesthesiologists, because as a medical specialty, we are incredibly unique. There's no job too small. There's no job too big. We do so many aspects of our day-to-day clinical practice have a lot of overlap with non-medical specialties. The things that we do, it's very hands-on. You have to use your hands as much as your brain.
Yeah.
You have to know how the hospital functions. You have to know hospital personnel. It also makes you appreciate, I feel like, the different roles that each person plays in contributing to the patient's care. I think I've always liked that about anesthesiologists. They know everybody in the operating room. That's not always true of every medical specialty, but I think there's a lot of satisfaction that comes from knowing the people that you work with, and I think that that helps keep people going. If you look at trends, however, like if you put the service basis of anesthesiology in context, probably one of the big concerns for even our current practicing anesthesiologists, but definitely I would say our residents who are still in training, is the continued conglomeration of anesthesiology.
Yeah.
Is just and that's reflective also in healthcare. So we're seeing a lot of important mergers that will likely influence the delivery of healthcare in the United States. We're seeing insurers and healthcare systems merge, and we're seeing some interesting investor-based organizations develop that may influence future models of healthcare. And anesthesiology, I think, is a critical part of every healthcare system in that we're necessary for key components of healthcare delivery, like surgery. We're also a very critical component of innovation in terms of surgery and invasive procedures, because you can imagine, I mean, I don't have to think that hard to remember when robotic surgery started, and how long it used to take to do some of the procedures that now take about half the time or a third of the time. But without anesthesiology, without the safe care of those patients who are having those procedures, surgeons and other procedural specialties would never be able to learn what they learn in order to advance their own field and provide that care for our patients. So you have to understand that that's part of our role too.
Right.
That we facilitate innovation. The concern, I think, is just that as a service-driven specialty, when and how do you foresee anesthesiologists becoming essentially nameless, faceless factory workers? And then, I mean, there's an image that I've used in some talks talking about the future of our specialty, and that's actually the image that I use. Is how do you keep yourself from being that person, where you're constantly being driven to perform faster, where if you're on assembly line making widgets and your part of the widget is like a sub widget,
Right.
and you have someone who's standing next to you with a stopwatch,
Yeah.
constantly trying to say, well, you did it, you can shave off a couple more seconds here and there. How do you keep anesthesiology from not suffering from those types of metrics? And I think that the way we do that is to continue to drive leadership. I think we continue to develop anesthesiologists who are willing to be part of the leadership structure of wherever they work. Because I also think that what goes along with anesthesiologists knowing how everything works and knowing the people in their environment is that we're also very well positioned to be influential administrators.
Yeah.
Because we listen.
Yeah.
And we fix things.
That's a great point. And actually, that's a perfect segue. I also wanted to ask you, you wrote an article on Kevin MD a little while ago about basically like the 5 reasons that I think physicians should be the CEO of every hospital. And you unpacked a couple points there. So can you maybe just briefly discuss that, the importance of having physicians in leadership, not only in like departmental leadership, but in healthcare leadership, and the hows and whys of why that's so important in your eyes?
I think this is really key, because I think we know today that physicians make up a very small percentage of CEOs of large healthcare organizations. And I mean, I would love to see that be greater, but I think we also know that those individuals who are driven, who are called to be physicians, don't necessarily do it because they want to eventually be hospital administrators. So we get that. They want to be doctors, and that's good. We need doctors.
Yep.
But I will say that certain aspects of physician training, I think, make them well poised to be physician administrators if they have that skill set. And because I also believe that people should do what they're called to do. And you can't force a good doctor to be an administrator, because that person is a good doctor, and each person, I think, should do what he or she is called to do.
Yeah. But
I will say that one of the most important aspects of our calling as physicians, I think, is really to be a productive member of society. And healthcare delivery, I think, is so critical to how society functions. I mean, if people get sick and they need to have surgery and they need to have long-term treatment for things, then they can't get back to contributing to society unless that process of improving, of recovering from surgery, recovering from illness, is as efficient and as evidence-based as possible. And so physicians have a lot to do with that. I think we understand that role. I also think that physicians, and I'll give the example of anesthesiologists in particular, I think are also used to coordinating with others to try to really accomplish a goal. Yeah. So in this case, like if it's patient care, then if we're standing around the operating room for a patient who is having an invasive surgery, say for example, and there are complications and there are things that we have to make decisions about quickly. We know how to make decisions even when you don't have consensus. We know how to deal with sometimes challenging personalities in order to do what's right. And I think that those skills, I think, translate out of the operating room into the boardroom just as well. I also think that we're constantly trained to look at our mistakes, our near misses, and improve. I mean, it's part of medical culture. We have morbidity and mortality conference in which we discuss cases that didn't go the way that they were supposed to go, and we use those as learning opportunities. And I think that if you talk to healthcare administrators, our managers, the people who walk around with clipboards around our hospitals every day, they're constantly talking about continuous process improvement. Well, that's not so different than what we do as physicians. We constantly look at the care that we provide and try to improve upon it. And I always give the example of the way that we learn to diagnose and treat illness. As a medical student, no matter what specialty you're in, you learn how to take a history, you listen to the patient, you examine the patient, you take the presenting symptoms, your exam, you order lab tests, you get those initial lab tests in order to try to inform your treatment decision, and then you institute a preliminary treatment. Well, as the patient recovers or responds to that initial treatment, you're going to take that information and decide, is the treatment working? If it's not, you're going to do something different. Yeah. You may get some lab tests back that take a little bit longer. And when you get those lab tests back, they may influence the way that you're treating the patient, and you're going to make a change there. And well, that same cycle is the exact same cycle as the continuous process improvement cycle. It just has different terms, right? Which means that every doctor, as soon as you finish medical school, even before you do your residency, you've already learned how to diagnose and treat illness, which to me, I think that the best hospital administrators, I think, really are diagnosis and treatment experts. And my bias toward anesthesiologists, of course, is that we do this faster than everyone else because we're in the operating room. Right. And when you have a crisis, when you have a change in vital signs, then you have to make that diagnosis and treatment cycle as fast as possible. And so I actually think that anesthesiologists are even better at rapid process improvement, but that's my bias.
Yeah, that makes perfect sense. And actually, that's a good segue. So I was recently speaking with Dr. Angie Edwards from Wake Forest, and she brought your name up and said that you guys were going to be collaborating a little bit in the future, and you're speaking at the upcoming SPACI conference, I believe.
I will be. That's right.
And she said that the genesis of that introduction and the invitation ultimately came over Twitter. And obviously you're an active Twitter user and a leader there. And I think Twitter is a way in which rapid dissemination of information has been revolutionized and brought like exponents from where we were even a handful of years ago. So I'm curious, talk a little bit about the way that you've used Twitter and social media more generally to shorten the lead time on instituting important changes or disseminating important information. And how has your, for somebody who's kind of interested in maybe becoming more and more savvy online with social media and specifically in the med ed community, how would you encourage somebody to think about that?
Yeah, so I actually started my Twitter account at that same spring meeting in 2013. Where I became in charge of the accreditation process or the pursuit of accreditation for the fellowship, and so that was a big meeting for me.
Yeah, no kidding.
Raj Gupta from Vanderbilt is the one who helped me set up my Twitter account.
Nice.
And I did not really know how how involved I would end up getting. I would say, like, at the time, I didn't have a Facebook. I still don't have a Facebook account.
Oh, I hate
But
Facebook.
yeah, I'm biased, but I just think, well, I remember the way that someone tried to sell Facebook to me a few years ago was, well, oh, it's a good way to keep track of what all those people in high school are doing
Right.
today that you lost contact with. And I remember thinking, or I probably said this out loud, I said, if I don't keep in touch with them, there's probably a reason.
Yeah. Yeah.
But so Twitter, I think was really appealing at the time only because it had very short messages. So the character count for Twitter when I signed up was only 140 characters per tweet. And Raj had shown me, well, here's some examples of what people tweet during meetings. And I thought, that could be actually pretty useful because you can't be in two places at once. Our upcoming anesthesiology meeting for the ASA in October is even a better example because you can't be in 50 places at
Right.
once, which is
Right.
what it feels like there. But I thought, well, with Twitter, I could actually see what people are learning because if they tweet some kernels of information, then I'll get a chance to see things that I otherwise would have missed. And so I started it from that reason, just trying to help summarize some of the key points that I would learn in a talk. If I'm sitting there, then I think, well, if people follow me, then um, they may be interested in the same topics that I'm interested in. So I'll tweet something that I think might be helpful information. I'll try to add a link to an article that the speaker talks about, so that way it makes it a little bit more useful.
Hmm.
And then I started figuring out, well, people actually like to see what you're seeing. So as long as there are no barriers to doing so, I would take a photo. And it's like taking photos is the modern note taking.
Yeah.
So I just say, well, I'll take a photo and then give some context to it. And so I'd start to share that way. And I realized that I started following a lot more people as part of being involved in Twitter. Just got involved in following people who like similar topics to me. And then I started branching out a little bit more, following people who speak or teach or write about things that I don't normally see, like leadership coaches, people involved in social media consulting. Um, I also started following other medical specialists just because I thought, well, this could be very relevant. I think to things that I do and things that I try to um, apply to my own practice. And so I started thinking of it that way, really as a learning community.
Yeah.
And that's probably the best way I could see at least a professional use of social media. I think the personal uses, I think aside, those are great. You can use, I have an Instagram account, and so that way I can share photos from whatever fun thing that I've done and see what other people have been up to.
Yeah.
But I find that Twitter is much more engaging.
Hmm.
Um, at least for people within our specialty, you'll see incredible activity around meetings, which is great because not
Right.
everyone can go to conferences. And so I always think, well, there are conferences that I'll miss in the future. There are some that I'll attend and others will miss. And with Twitter, you don't have to feel like you're completely missing the learning opportunity,
Yeah.
which I think is great. And
Yeah.
then when we see good articles, we always we try to share those with each other. And then a friend of mine, a great colleague, Ankit Udani, who is one of our former residents and research fellows here, he's on faculty at Duke and started the Twitter Journal Club for anesthesiologists.
Oh, nice.
And that really changed I think, a very traditional method of teaching emerging research because everyone who's gone through medical training has had a journal club.
Yeah.
But you take that and you layer on top a Twitter conversation. And now not only you're getting an international perspective, which you can use locally to try to teach your trainees so that way they can see different points of view. But oftentimes you'll actually get the authors of the paper involved, which is unheard of.
Yeah. How
So
exciting.
it's
Direct
really cool.
access. Yeah.
It's really cool. So I do think it's become an incredibly powerful tool. And I think professionalism, of course, always has to be considered, when posting on social media. But there are way more advantages than disadvantages I see, at least for at least a modern physician, a modern scientist in being involved.
Absolutely. And I know you've done so. I think I've seen a white paper with your name on it that was like, here's the social media for dummies, basically for physician or the med ed community. And I know there's a slide deck or two out there. I want to link to these in the show notes for everybody. So for our listeners, if you go to anesthesiasuccess.com/30, I want to Ed has created a lot of great resources for people who are trying to get up to speed on proper or recommended uses of social media in order to further medical education. So make sure and check out those resources there. And I'll try to get a few more of those links. We'll link up to the Twitter Journal Club and others.
That'd be great.
So I want to bring it to a close. And I really appreciate your time here today, Ed. To close this up, I'm curious, of all the things you're working on right now, maybe give us a snapshot into like one or two of what you see as the most important or the most rewarding or the most worthwhile ways that you're spending your time right now. And what does that look like? Just maybe it might just be like if you take us into like a day in your life. What does that look like for you?
I think a day in the life is a little harder because I think that each day is a little different.
Yeah.
But I would say that the things that I've reflected on, when I'm getting involved in different projects, especially today, as compared to when I first started my career, I have thought that the things that I get super excited about, and I'll give you a real example just from this morning. I got an email from a colleague with whom I've done projects before, and the email was just a brainstorming idea. Like, what do you think about this particular project? What do you think? Who do you think would be good collaborators? What do you think about this possible study design? And I gave it some thought. And this morning, I wrote this person back and gave some alternative suggestions. I said, that's that's a great idea. It's an interesting concept. It was something that we had written about together as like an unanswered question in the past. But I considered some alternative study designs and gave this person a couple of other ideas. And then also gave some advice about, whether or not you may want to consider, diversifying the collaborator pool, with whom you normally work, and just to try to, expand your research group, try to get other opinions, people who maybe don't always agree, as I mentioned before, which I think is really a good thing.
Yeah.
Also to try to vet potential collaborators to see, like, are people willing to do the work? There are a lot of people who want to say they want to be involved in projects but aren't willing to do the work.
Yeah.
And I think after that, I sent off that message. And I started thinking about how my own perspective has changed. I think as a not just as a clinician scientist and as a mentor. And I look at my own productivity, and I have to say that in the years that I've been in my current position, my current administrative role, I really haven't focused so much on my own primary research direction as much as I have tried to listen to other people who are developing their research directions and tried to help people find their own path and help them with other ideas. And I have to say that if I compare that approach, really less focus on myself and more on other people, versus the early part of my career, which was very self-focused and trying to determine my own research path and consistency and developing reputation. If you look at my publication productivity, it's much greater in the latter part of my career, where I've been less focused on myself. And so I would say that a good part of what I do in terms of teaching and mentoring is really trying to listen to what people want to do with their career. And I think that unfortunately the pipeline of academic physicians is not super strong. I think we could use more people. We need to try to recruit and retain the people who have enthusiasm, and for that we'll need some really good mentors. Probably the second thing that I would say is a heavy influence right now is probably the work I'm doing with the National Academy of Medicine. It's a project that's been going on for about a year. And what I like about it is that it's a public-private partnership. It's on a national level addressing the opioid epidemic. And I've had a chance to directly work with representatives from multiple government agencies, plus nonprofits, other professional societies. We have an interesting very broad, as you can imagine, a set of objectives. But yeah, I sit on two work groups, the research and data metrics, and another work group about pain management prescribing guidelines and evidence standards. And I think that what I've learned, I feel like in this process so far, is just how many people, not just one, like care about, right, what we're dealing with in terms of the opioid epidemic, but we have a lot of people who really care about the pain that people are suffering from and trying to improve pain management. And I do think that at the end of this, of the work that we do, I mean, nothing is going to be solved, of course, but I think we'll make some really big steps. I think one, in terms of defining what good pain management looks like and providing some research direction, I think, for answering some of the unanswered questions that can help people suffering from pain. I think we will have some guidance on providing non-opioid alternatives, and hopefully we'll be able to work with some of our insurers and other government agencies on trying to make sure patients have access and proper payment for those effective pain modalities.
Yeah.
And then I think another thing that will be really key is integrating good pain management education into all levels of health professionals education. And that's one of the other work groups, that we're working with. That's one of their objectives. And then the other work group that I think is really critical is just acknowledging that addiction is a brain disease and try to remove some of the stigma associated. Because I do think that we're all learning with the opioid crisis that that there's no quality control in terms of how people recover from opioid addiction. It's not like you can go on Hospital Compare like we can for other aspects of healthcare services and see how those facilities are compared against each other in some national metric. There are no national quality metrics, but I think we can't address the crisis of prescription and illicit opioids without taking care of the people who are suffering from addiction. And I think that those have to go together. I think we have to provide a comprehensive system, that manages pain well, that defines when opioids are appropriate, because they are. They have indications. But we also have to take care of the patients who have become addicted and who are trying to decrease their dependence on opioids and have support systems for them too. So that's a project that I feel super passionate about right now, and I'm looking forward to a lot of the new work that we're going to do in the coming months.
Yeah, awesome. Cool. Well, I really appreciate you sharing that. And Dr. Ed Mariano, it's been a pleasure speaking with you today. Thanks for joining us on the Anesthesia Success Podcast.
Thanks, Justin. Appreciate it.
If you liked what you heard this week, head on over to apmsuccess.com, where you can find more content and free resources to help you build a successful career in anesthesia and pain management. If you wanted to leave a review in iTunes, I'd also really appreciate it. Thanks for using some of your valuable time to join me today on APM Success.